Hello, welcome to the Lupus Forum's EULAR 2022 Congress review. You may have seen that we published a summary of all the most important abstracts at the conference that you can use if you're still navigating it online. Well, today we're going to be covering some of the key Lupus content from the Congress in more detail. So whether you're able to attend or not, this is your opportunity to catch up on anything you might have missed. And it's my pleasure to be sharing this review with Laurent Arnaud, who's a professor of medicine from the Strasbourg University of Medicine in France. Hi, Laurent.
Hello, hello.
And with Professor Victoria Werth, who's the chief of the Division of Dermatology at the Philadelphia Veterans Administration Hospital in Pennsylvania. So thanks both for joining me. So we talked about this at the conference, and I know you agree that it was just great just to be back at EULAR face-to-face in person after 2 years attending virtually, wasn't it? Having the chance to meet up with people.
Yeah, it's great.
Yeah, I mean, you realize what a difference it makes, don't you?
Yeah.
And so we're going to talk a little bit more about the lupus data that was presented. But I just thought before we start, what of all were your personal highlights? Victoria, do you want to kick us off on that?
Sure. Well, I mean, I think we're going to be discussing these here. What I felt was very interesting, but we gave an overview of cutaneous lupus and its treatment and advances. And then I think some of the work related to blocking type 1 interferons is really fascinating and this includes, for instance, the Bib59, which is an anti-BDCA2 antibody, as well as anifrolumab, which we're all becoming very familiar with, and then deucravacitinib, which is another way of blocking the interferons. And so I think that that was a big highlight for us.
Yeah, I agree. It's a whole new class of therapies, isn't it? Laurent, what would you say were your highlights?
The anti-CD19 CAR T cells, because we definitely need new ways to tackle the disease, and the results, especially in the context of lupus nephritis, is really amazing. So this is definitely something to look very closely, I think.
Yeah, and that was creating a real buzz at the conference, wasn't it, that abstract? So we're going to talk about that one in a bit. I mean, I think for me, one of my highlights was actually I chaired a poster session and I just saw loads of new researchers working in lupus, young researchers, PhD level, who I'd never met before. They've sort of started it in the whole period where we haven't had live conferences, and it just really felt like a lot of energy, really, I thought.
Yeah, I definitely agree with this. A lot of energy around lupus. That sounds really, really nice.
And that sounds like a great place for us to start talking about the highlights then, doesn't it? So I think, so Victoria, you're going to talk about some of the joint and skin session that we were talking, some of the abstracts that follow from that.
Yes, of course. And so I think it's really important as we discuss some of these potential advances and new advances to realize the huge impact of lupus on the skin and on quality of life for patients. So we discussed a bit about that. I think as we get new therapies and as we try to get new therapies through trials, it's important to make sure we're treating lupus and not a mimicker such as dermatomyositis. We have found that about half the patients I see with dermato are referred in with other diagnoses, and about a third of those are SLE. So really need to hone our clinical skills in that regards. Need to think about PPIs as a potential cause of subacute cutaneous lupus, and about a third of the time we find medications that are definitely related to triggers. And then we discussed a number of approaches, including the immunosuppressives, which work about 60% of the time, and then lenalidomide, which is a pretty effective drug, but rather expensive and with less peripheral neuropathy, which is great. Iberdomide, which is a derivative of lenalidomide. There was a recent New England Journal article that was discussed showing that it does seem to work, particularly in SCLE and to some extent in DLE, but more so than in acute cutaneous lupus. And then the idea that drugs such as rituximab may be not the appropriate therapy for discoid lupus and SCLE because there's been new onset or exacerbation of those particular types of patients. Belimumab can help skin, but does seem to have effects rather slowly. And then we're going to talk a lot more about the cytokine and interferon type approaches to drugs.
Yeah, I mean, I was in that session as well. This is on the screen there now. I mean, and the thing I really thought was that we essentially license drugs for non-renal lupus based on whether we can measure improvement in joint skin involvement. But how often do we really go into the details of those organ systems and the real nuances of assessing them properly, the different sort of details and manifestations we might see, the different therapeutic targets and why they might matter? And I really thought it was very good to get into some of the detail on that. I think we need to do a bit more.
I agree. So this particular study, I guess I'm going to discuss briefly, is about the efficacy of BIB59 on skin manifestations in participants with systemic lupus in the phase 2 LILAC study. And I think it's important here, first off, to say that one of the reasons for doing this is that clearly the goal is going to be clearance of skin activity as a desirable outcome, but one that's rather difficult to achieve with current therapies. So the question was, how often do we actually accomplish that? And we know from the phase 2 trial that has been previously presented that patients really did quite well relative to placebo in terms of the skin. And so the issue here was how many actually can accomplish clear or almost clear. And so you can see the numbers are relatively low, but there are some, and it's definitely more in the treatment group than placebo. And so that was really the point of this abstract, and to say that this is really intriguing and is a rationale for going on and looking further in an upcoming phase 3 trial at the skin, and an ongoing for SLE trial and looking at the skin as well.
Yeah, I mean, I thought, I mean, it's interesting what you were saying, like this interferon is this class of therapy, and we've got anifrolumab, which is licensed, and then this one, which is quite advanced in its development, and how those differ. And the way obviously this is aiming to target PDCs, and I think that's interesting. In the skin, you've got other interferon producing cells as well. You like keratinocytes, fibroblasts, they all make interferon. Okay, they don't make it as fast as a normal PDC does, but there's an awful lot of them. And I just wonder if that will differentiate between patients who are suited for one therapy or another.
Yeah, I think we still don't know the answer to that. I mean, I think the interferons and the keratinocytes are probably part of the photosensitive response, but once you initiate the inflammation in the skin, I think the other cells are probably also critical in terms of their production of interferons. And I think that it remains to be seen which are the major cells, and there may be a lot of crosstalk between PDCs and other cells.
Something which I think quite amazing is the speed of action. It's definitely crucial in case of skin involvement. We don't want our patient to keep skin lesion for a long time. Can you comment on that regarding to BIB059?
Yeah, there's another study, which I believe might even be the next one, where we're talking about, we're going to be talking about anifrolumab, but the speed is rather rapid, and within a month you can start to see effects of blocking interferons. And that's been true really with all of these different approaches that have effects on type 1 interferons. There's continued improvement after the first month, but you can really see an effect quite quickly, and that's really what makes this so exciting.
Yeah, very exciting.
So we're going to, I guess, move on and talk a little bit now about anifrolumab. And this is, as we've talked about, an antibody against the type 1 interferon receptor, and blocks really all type 1 interferons in terms of their response. And so one of the studies was looking at anifrolumab in terms of the effect on mucocutaneous manifestations of patients. And here the question is, really, can we, this was based on the TULIP-1 and TULIP-2 trial, which were phase 3 trials that in the skin both showed improvement based on the CLASI, which is a validated outcome measure for skin and lupus. And so the post hoc analysis here was to compare 300 milligrams of anifrolumab using the CLASI to the placebo group. And basically what was looked at here was a group that was multi-domain, meaning they had erythema scale and other manifestations of lupus in the skin, or that they had more erythema as well as at times some of these other manifestations. And what you can see is that if you look at the reduction from baseline, in terms of the CLASI, the erythema went down dramatically in the group that had multiple manifestations from 63% to 40%. And in those who had more erythema, a similar, a similar decrease was seen in the degree of erythema. And then if you drill down on the patients who had presence of scale or hypertrophy. What you can see here is that the multi-domain group, meaning those who had more than one manifestation and a certain degree of manifestation, the erythema scale, mucosa, and hair, you can see again that there's quite a drop there from 72% to 42.6%. And those who had enriched for more erythema, also very, very large drop. So this really speaks to the efficacy that we're seeing with anifrolumab and the different components that can be dissected using the CLASI for showing that improvement. And then if you look at other things such as alopecia or mucous membranes, what the goal here was just to show that there was no worsening from baseline. And that's in fact what is you can see with both alopecia and mucous membrane. There's really no particular difference between those two groups, those who had multi-domain and those who had increased erythema, both for alopecia and for mucous membrane. So the bottom line is that there are improvements seen with anifrolumab in SLE patients with the skin manifestations. And this again supports further evaluation of this approach in patients with primarily cutaneous lupus.
Does this mean that the effect of anifrolumab on rashes like erythema and scale is better than what it does to alopecia and mucous membranes? Or is it just that it's hard to measure, it's hard for those things to show improvement?
Well, I think part of it is that alopecia takes longer to improve, and that's only part of the issue. And I think it depends on which type of alopecia we're talking about. I think if it's diffuse alopecia, the question becomes, is that even, due to lupus activity, or could it be another component? And so it may be harder to show improvement, but the goal here was just to show that it didn't worsen.
Yeah.
And, one of the questions from a regulatory standpoint is, well, so what aspect of the disease is getting better? And so this is a way of dissecting that to be able to know that.
Yeah. On my side, I don't really have a specific question, but obviously we are all following patients with very severe discoic lupus. And this can be a very, very destructive disease. So I'm quite happy to see that it's moving on to specific treatment for CLE. We obviously have some options for SLE, but true options for CLE are really lacking. So it's nice to see that pharmaceutical companies are also tackling this challenge, I think.
It's very, very important because there really has not been a drug approved for cutaneous lupus in many, many, many decades, and we need new therapies. And I think it's important to point out that because the approval is for SLE, that it really doesn't mean that patients with CLE will automatically get this approach. So we really need to study CLE.
Mm-hmm. I agree.
And so this is another study that highlights, I think, the potential efficacy of anifrolumab, and there were some very dramatic pictures here showing improvement rather rapidly in patients who received anifrolumab 300 milligrams IV every 4 weeks. And the look was at 8 SLE patients in terms of what happened to their skin scores. And these were a range of patients. Some of them had been refractory to rituximab, some with discoid lupus, and some of the biomarkers were followed, including type 1 interferon expression, as well as looking at some other features of biomarkers. And it's very clear that when you look at both the skin manifestations, including the CLASI score, that there was a very rapid improvement in the patients who had predominantly SCLE and DLE. And then also that there was a rapid decrease in the interferon score, the interferon alpha score, as well as the plasmablast tetherin, which is important as well, and a manifestation of the effect of blocking the interferons. So I think, again, highlighting the effectiveness of this potential approach for patients with cutaneous lupus.
Yeah, so this was actually from my center, and this links exactly back to what you said at the start, that when we first used rituximab, we noticed that although it seems to work on most of the organs, we saw some of those patients, the other organs were improving, but the skin was just not responding at all. And some of these patients, a lot of these patients were one of that kind. There were people who had rituximab for their other features of SLE, but it never worked on their skin, and they were incredibly difficult to treat. We tried everything possible, and I knew them for years, and with constantly active disease. And when they had anifrolumab, it was just amazing. They had one infusion and it was just gone after 10 years of disease activity. So yeah, like you say, the photographs, we can't reproduce them everywhere, but they were impressive.
Yeah. Yeah, very interesting work, and hopefully more to be presented in the future.
Yeah.
So belimumab. So we are obviously convinced about the efficacy. There's a huge development program. The drug has been licensed since 2011 in Europe, and then this year we have an extension of indication in lupus nephritis. But still, this is about efficacy, and as always with our immunosuppressive agents, there are potential concerns about tolerance. So this is really interesting because it's a very thorough study. There are more than 4,000 patients who have been encouraged to receive belimumab about the safety, so especially mortality and malignancies. So I'm just going to summarize this very briefly, but it's a very huge sample of patients being treated with belimumab plus standard therapy for 48 weeks. In the end, we see that there's a lower cumulative mortality rates, as well as reduced rates of new primary malignancies for the years 2 and 3. So this is a very large, even the largest double-blind trial of SLE to date, and it supports the safety of belimumab, which is of course important. We had efficacy data, but obviously we need some more data about tolerance.
I mean, one thing I was struck by looking at this was that I know that these aren't necessarily, maybe these are numeric differences, but the description is that a lot of these safety parameters were actually better in the belimumab arm compared to the placebo arm. And that's a theme that you see across quite a lot of different lupus trials. We saw it in the rituximab studies and in the obinutuzumab nobility study, that some of the safety data, like SAE rates, were actually lower on the active arm than they were on placebo. And it just makes me always think about the things we tell our patients when we're talking to them about taking these biologics. We sort of seems natural to say, oh, this is an immunosuppressant, it might increase your risk of infection. But actually, the safety concerns just aren't there, and patients need to know that.
Is there evidence that the rate of use of immunosuppressives, meaning truly like either mycophenolate mofetil or azathioprine, is lower in the group that's given belimumab, maybe accounting for some of the differences in malignancy? Do we know that?
Well, we already have data actually, and I think the safety profile was quite reassuring. There's a mean rate of infection around 3 for 100 patient years, which is less than most classical immunosuppressive agents. So I think this study really nails it and shows that the overall tolerance of belimumab is actually very good. And this is obviously very important because many patients receiving belimumab are receiving it for several years. The next study is actually around the combination of belimumab and rituximab. And I think this is really fascinating. There are 4 randomized controlled trials with quite similar designs. We've been knowing this for a long time, that when you give rituximab to the patients, you deplete the B cells, and so there's a peak of BLyS, the B lymphocyte stimulator, after the depletion to try to repopulate. And the idea is to come on top of that with a BLyS blocker, which is belimumab. So from a rational perspective, it's very, very interesting. And obviously, we have 2 main questions here. What's the efficacy of this combination, but also what is its tolerance, because we're adding 2 different monoclonal antibodies in the same patients. And well, this is quite interesting. This is a randomized controlled trial, 104-week study. The patients receive this combination of belimumab and rituximab. And very briefly, you have some strong immunological effects that were expected. But what is a bit disappointing is that there is no very marked improvement in terms of disease control. And that is, in a way, a bit disappointing. On the other hand, the safety is quite okay. So this leaves some room for the optimization. Maybe we should change the time frame, the way these drugs are combined. But this is definitely something to think about for the future. But for now, no strong efficacy of the combination.
And there's another trial we're looking at later, or at least a post hoc analysis that does do one of those other combinations, isn't there? Beat Lupus 2 that's coming up at the end. But I think the other thing I thought looking at this was that, again, a recurring theme when you look at B-cell targeted therapies is this idea that with belimumab alone or with rituximab alone, do we really hit B cells hard enough to get the best responses? And in here, okay, there wasn't a clinical difference demonstrated, but there were antibody titers could be lowered further with the combination than the single agent. So I do still wonder whether the agents we use really hit B cells hard enough. And of course, that feeds into the CAR T cell abstract that you mentioned.
Yeah, absolutely.
Okay, so I'm going to talk to the abstracts about voclosporin. So, you know, again, since the last time we had a face-to-face EULAR, we've got lots of positive studies. We've got 2 new therapies licensed, anifrolumab and this one, which is voclosporin, and this one's for lupus nephritis. So if you're not already aware, voclosporin is a newer generation calcineurin inhibitor in the same class as cyclosporin and tacrolimus, that's designed to be used in combination with mycophenolate in the treatment of lupus nephritis. And the main studies already out, which showed that when it showed approximately a 20% difference in the response rates between patients who had mycophenolate and steroids alone versus those who had mycophenolate, steroids, and voclosporin. Something like complete response was something like 41-23, and partial response something higher, 70-50%, about that difference. Another interesting feature of that main study, if you do look it up, is that the steroid regime they used was a lot lower than we might be used to, which is another, I think, on its own an important breakthrough. But anyway, this is about a long-term follow-up, and it is important because when we look at those response rates in the typical lupus nephritis phase 3 trials, you might be looking at 12 months, 18 months time, and then looking at a proteinuria response, and that's what we do to compare therapies. But of course, preventing proteinuria isn't the whole reason for treating lupus nephritis. The reason for treating lupus nephritis is to prevent renal failure, and that may take longer, and that's why it's important to get studies like this that look at long-term extensions. So there's another 2 years of follow-up here, so three in total of the original Aurora study. And essentially what these outcomes show is that the benefits of the voclosporin, the clinical improvements that were seen in the 1 year period were maintained over the 3 years of the study. There were some concerns as well with calcineurin inhibitors, that maybe we know that calcineurin inhibitors can sometimes lead to some reductions in EGFR, which in the main study, they were quite temporary, and there were certain rules in the study that if it only dropped a small amount, you could monitor, or you had to stop the drug temporarily, or sometimes stop completely. But anyway, that's again what's important to see here, that in the long term, the renal function remains stable in the 2 years follow-up of these patients. So it's just emphasizing the benefits really of combination therapy. And my impression from this has been that probably the days where the standard therapy for lupus nephritis should just be mycophenolate combined with high-dose glucocorticoids, I think those days are going to be coming to an end. And I think patients really are going to all be needing combination therapies and less glucocorticoids.
Yeah, I think these are very interesting results. Still, we have not seen yet the results of the renal biopsies. There are different ways through which voclosporin can actually control proteinuria, mechanical action or immunological action. And I think we really need the proof that actually the inflammation is inside the kidney is controlled with the drug. That is absolutely crucial, and it's not been shown or published yet. So I'm definitely waiting for this.
Yeah, I agree. That's the problem with essentially with a study where the primary endpoint is largely based on proteinuria. It's like a surrogate endpoint, isn't it, rather than the real issue we're trying to prevent. So yeah, I agree. The biopsies,
especially true with this family of drug which have an intrinsic proteinuria blocking effect. So
yeah, it has this direct effect on podocytes to stabilize them, doesn't it? Okay, and then we've got one more study that's also about voclosporin. So this is, again, a reanalysis of the trial data from the phase 2 study, which is called AURA-LV, and the phase 3 study, which is called Aurora. And the reason for this analysis is that EULAR and ERA have been updating some of their guidance on what the most important endpoints are to achieve in lupus nephritis. And so the study was then reanalyzed to look at those new updated endpoints. So a protein creatinine ratio less than 0.7 at 12 months has been shown to be a really good predictor of renal failure. So that's why that's important, the one in the middle there. And again, you see about a 20% difference in the rate of that between the voclosporin and the placebo arms. And then if a protein creatinine ratio less than 0.7 can't be met, then what else do we want? We want a 50% drop. So you can see that there, 66% on voclosporin, 47% on control. And then another thing, when we're using in the clinic, when we're using proteinuria to look at how treatment is going, I think one question I'm always asking myself when I start some kind of therapy is I don't want to wait 6 months or 12 months. I need to know early if it's going in the right direction or not. So what you want to see then is can we see improvement by 3 months' time with a 25% reduction at the 3-month time point. And again, you can see that was evident in 78% of the patients who were getting voclosporin. The last part, of course, and this is a common theme across all of lupus, as I think everyone watching this will know, is emphasis to use less steroids. And that was quite easily met here because the whole protocol had a very low steroid regime where patients who were over 45 kilograms were started on 25 milligrams of prednisolone, and it was tapered to 5 milligrams by week 8 and 2.5 by week 16, which is a lot lower than some of the previous protocols have used. So it's met quite easily here.
And we know so many of the side effects are from steroids in our chronically treated lupus patients. So I think it's really significant to show that maybe we can get by without quite such high doses.
Yeah, especially things like those safety outcomes we were looking at earlier. Steroids probably predict some of the safety problems like infections more than the investigational drugs in these trials.
Right. So I think I'm going to be moving on and talking a little bit more about cytokines again, but in a slightly different way. And so this is going to be talking about the results from, well, actually the baricitinib will be first, and then I'll be talking in a minute about deucravacitinib.
Yeah, I thought I'd do baricitinib. I'm an author on it, although I don't necessarily know all the answers to the questions here. So I think anyone's welcome to chip in, because this is quite an intriguing result, a quite surprising result. It's difficult to understand. So baricitinib makes an awful lot of sense in lupus because we know it from other inflammatory arthritis. It inhibits JAK1 and 2, approved for rheumatoid arthritis. Well, one of the cytokines that blocks is type 1 interferon that we were talking about at the start. So baricitinib should block type 1 interferon and have those benefits, and it should block some other cytokines too. So it makes lots of sense. It had a positive phase 2 study that looked quite good. There were lots of PD data from that study that were published that make a lot of sense. So there were 2 parallel phase 3 studies called BRAVE-1 and BRAVE-2 done in non-renal lupus, skin and joint disease, identical protocol, large numbers of patients. And we have this result that in BRAVE-1, the primary endpoint, which is the SRI-4, as commonly used in lupus trials, was met. In BRAVE-2, that primary endpoint was not met. Well, that's not that uncommon that the two phase 3 studies disagree with each other. Not that uncommon in the lupus world. But very disappointingly, none of the key secondary endpoints were met in either of those studies, although some of the exploratory ones were. And that really means that the whole program is very inconclusive about the benefits of baricitinib, which is a strange result. And maybe it hints back to what we were saying earlier, that it's all about how good are we at recognizing and rating these different features and how well do these instruments do that. I kind of think my takeaway with this was that trials in lupus don't always tell us the truth. We know they don't because they disagree with each other about the same questions. And the other thing I kind of thought from looking at this is there are aspects of success that aren't written in the protocol and aren't written in the paper, and what makes a trial successful or not. And it may be something to do with the really detailed conduct of the study. I don't know if either of you have any other thoughts about why we get results like this.
Well, I think part of the issue is when you go from phase 2 to phase 3, it's a much bigger study and it's much harder, I think, to have rigorous appropriate patients enrolled. And so it's not uncommon to get a positive phase 2 and then have phase 3 not work out quite as well. And I think it speaks to the need of trying to get patients with severe enough disease that you can actually see differences. And sometimes it's really difficult to do in a disease where it's not as prevalent as some.
Yeah, I also think it raises interesting questions about the primary endpoints. It's always the same. Here's the SRI-4. We know there are some strengths, but also some important limitations. And what I really appreciate was the recently published paper where the authors study the patients who are both bipolar and SRI-4 positive or discordant. This gives very interesting information as to how to include patients in SLE trials. So maybe this is going to be interesting to apply that kind of methods to this paper.
Yeah, so in the anifrolumab program, there was a similar thing, wasn't there? That the SRI-4 was different between the two anifrolumab studies, although the BICLA was more consistent. And we all scratched our heads over that one at the time. And one of the things actually that stood out to me as a potential issue is that, so anifrolumab, we all think it's particularly good for skin disease, but you only get 2 points for rash on the SLEDAI. So actually a 4-point improvement is quite high. You can't meet it even if you have a dramatic change in your rash unless something else improves, perhaps the alopecia or the mouth ulcers, but like we saw, those don't improve so well. So depending on which therapy you're investigating, the outcome measure may be more or less appropriate. And I think it does all need to be thought about from scratch, really.
Which is an ongoing effort, which I think, hopefully we will get better instruments, and also having disease-specific instruments, I think, can be very, very helpful in this situation.
A combination of both is really important, I think.
Yeah, so there are efforts in progress to change these outcome measures. Okay, should we go on to the...
Yes, and I think I will be happy to describe the results here, the deucravacitinib study. And this is an oral selective allosteric TYK2 inhibitor. And so it has effects not just on type 1 interferons, but also on IL-23 and IL-12. And these are thought to be important cytokines in lupus pathogenesis. And so this is really a drug that's found to be working in psoriasis and psoriatic arthritis. And so applying a drug with, a little bit broader effects through TYK2 is certainly of interest. And so this was a phase 2 study of active SLE, a 48-week randomized double-blind placebo-controlled trial. And you can see there were 3 doses and then placebo that were looked at. And in particular, the lower dose of deucravacitinib seemed to be quite effective relative to placebo, with you can see 58.2% improvement versus 34% looking at the SRI-4. And so there were also similar significant differences seen with the BICLA, with the LL-DAS, and then also with the skin measure, the 50% improvement in the CLASI and the active joint count. And so this looked to be a very interesting phase 2 study that definitely will lead to phase 3 and trying to understand more about its efficacy. And so it also was very well tolerated. The main effects were URI and nasopharyngitis, headache, and UTI. So the sustained clinical efficacy is of interest, and certainly will be another drug we'll be looking at as it moves on to phase 3.
So the benefit of targeting TYK2 rather than JAK1 and 2 like baricitinib is the specificity for the cytokines that are of interest. Is that the idea here?
Yeah, and also the expanding to include IL-23 and IL-12, which are also affected and may be important here.
Mm-hmm.
Makes sense, yeah.
Okay, the last one is about orelabrutinib, which is a BTK inhibitor, proton tyrosine kinase. I think we all have in mind the failure of fenebrutinib in systemic lupus, so it was very interesting to see the data about another one, orelabrutinib. So this is a phase 1b/2a trial, so obviously relatively small sample, 60 patients randomized to receive different dosages of orelabrutinib. As a summary, I would say that first, safety is okay. There are treatment-related adverse events in 3 patients, but I think it's important to say that one of which was a grade 3 event. But as an exploratory measure, in a way, was the SRI-4 response improved in a dose-dependent manner. So they are definitely moving on to further development, and well, we're crossing the fingers. Maybe we'll have a new family, new tool in the therapeutic arsenal for systemic lupus.
Yeah, and it just makes me think again about, you know, different ways to target B cells, blocking BAFF, BTK inhibition, depletion. You just wonder again, don't you, about the combinations of these things and whether do some of those suit some patients work better more than others? Is one method just the best overall, or do we need to think about combining these things? It's fascinating field.
I think any new treatment in the field of SLE raises the question of what is the best patient for this given treatment, and combination treatment is obviously an option.
Another might be targeted therapy to identify the biomarkers that will identify who might respond to one therapy over another. And I suspect that will be the direction that we go in the future.
I agree.
So I think that's a perfect link to the next abstract. So we're going on to the emerging therapies now, the things that may be a little bit more at the experimental end. And this is the one that that you said, Laurent, you said was your highlight. So this, you know, this is only a 4-patient study, but it created an awful lot of talk at the conference. It was the real buzz. And this is going back to, again, the theme about how do we target B cells the best. And it's an immunotherapy idea borrowed from oncology. So just briefly, what happens here is that this is a way of getting T cells to target the B cells. So they take T cells from the patient. In the lab, they insert a gene for a chimeric antigen receptor. So that's the CAR. So and then grow up these T cells that express this chimeric antigen receptor, and then give those back to the patient. So then those T cells will then target, and it's that chimeric receptor is to CD19. So then you've got T cells that are targeting CD19. So it's a bit like having a cell-killing drug, like rituximab targets CD20. This targets CD19, which has a slightly broader range of expression. But that antibody is tied to a living cell that has very potent natural cell-killing properties. And this is the reason for doing this is essentially a way to hit B cells harder and in a more sustained way, and keep the numbers low, and probably deplete B cells in certain tissues and so on better. And so, okay, it's an open label case series, and we all know that those you need to see results of true trials, but it did seem striking that these patients who had been quite difficult to treat had extremely good sustained remissions.
I mean, so one thing that's, I guess, a little bit interesting is why it was so much more effective in some ways than other B cell depleting approaches. Do you have any thoughts about that?
That was exactly my question too. And I think there's a couple of things I can think of. One is that maybe B cells within inflamed tissues may be much harder to kill. CD19 has a broader range of expression, and maybe CAR T cell therapy against CD19 just has a more potent effect at getting rid of the B cells that matter. Another, of course, is that when these case series that are done in specialist centers, the people running them will select their patients very carefully. And they know what they're doing, and they choose the patients who really need that mode of therapy. And I think that's, when you look at the open label case series of rituximab, the response rates are much higher than you see in something like the Explorer study. So there could be a number of different reasons. Of course, like we said when we were talking about the cutaneous disease, in my opinion, there is some of the inflammation in lupus patients is kind of a bit B-cell independent and won't really respond to that line of therapy. So I do think one treatment is not going to be right for everyone.
Right.
Yeah, I think this is really amazing, but an important limitation for now is the cost. So we obviously had to wait for more, but this is really, really promising. So the results are amazing, actually.
Yeah.
Okay, now let's move on to the clinical outcomes in a way, clinical practice. I really like this randomized control trial, which is a non-inferiority trial that was done in France, actually. Is about the question we have every day when you are treating lupus nephritis: for how long should you go on with the maintenance treatment, especially in the context of MMF or azathioprine and so on. And so the patients were randomized either to stop immunosuppressive agents after 2 to 3 years or to go on. And non-inferiority was actually studied. And unfortunately, that's a bit disappointed that the non-inferiority of the maintenance treatment discontinuation after 2 to 3 years was not achieved. So in a way, the main goal that was to demonstrate that it would be better to go on with more than 2 to 3 years compared to less than 2 to 3 years is not shown, which is what we were expecting in a way. But still, I think there are some interesting messages, especially the risk of flare and of a lupus flare was numerically higher in the group of patients discontinuing. So I think that there are some interesting data to get from this paper.
It is really important because I get this question in the clinic all the time, patients saying, I'm better now, can I stop these therapies? And I always say, look, we know if you stop it, there's a risk of relapse, and the longer you go on for therapy, the longer you go on, the less the risk of relapse becomes. But honestly, when's the right time to stop it? Nobody knows. And that's why these studies are so important. And the other thing I thought about here was that, as I was saying, it's in my opinion, I think we're in the future is going to be all patients having combination immunosuppressants, that they won't just start on mycophenolate and steroids. I think a lot of patients with, at least with over a certain level of severity, probably ought to have multiple immunosuppressants, and then you'll be gradually wanting to take them away as a kind of reverse pyramid of therapy. So it becomes really important to understand the time points at which you can do that. So to me, this is really practice changing because it tells me if someone asks to stop their therapy before 3 years, I'm going to advise them against it.
Yeah. And I think the other point is just it's a fairly small number of patients, and this is a difficult study to do, but there is a numerical difference in terms of relapse of proliferative GN, and you would undoubtedly, with more patients, be able to potentially get a statistical difference here.
Yeah, I think that's the most interesting outcome, actually, although non-inferiority was not demonstrated for the primary outcome. Okay, this one is very much about the window of opportunity in the context of systemic lupus. There's been lots of papers about LL-DAS. And well, we know that attaining LL-DAS is associated with a reduced risk of damage, flare, mortality, quality of life, and so on. So these are very, very important outcomes. But it was not so clear in patients with recent onset systemic lupus. And here is quite interesting study because this is a large sample of patients, more than 4,000 patients, including around 680, which were taken in the cohort within 1 year of onset. So they call this the inception cohort. And what they show is that actually you still have benefits of LL-DAS in terms of protection against the flares, especially in both cohorts, but including of patients with recent onset SLE. So I think this is very much the extension of the data we already have to this inception young SLE cohort, which is really key, like a window of opportunity.
Yeah, one of the things I thought here was that, and I think these studies are really important, aren't they? That they tell us that we keep monitoring patients to see if they're a low disease activity. And the suggestion is if they're not in low disease activity, you have to keep changing therapy as much as you can until they are, and try and maintain that. I think one of the things I always wonder about there is that, of course, there are some patients who are just generally have milder lupus, who they will get more time in low disease activity almost whatever you do. And there are some people where it might be they have very severe lupus, it might be very difficult to get them into low disease activity. So I guess that's what I wondered about, is whether, does this tell us that achieving and sustaining low disease activity, is it definitely due to something I did rather than just a milder disease? And I think that's what I always want to know about, to understand how to implement these protocols.
Yeah, I mean, it speaks to the disease heterogeneity and just a lot of the problems of trying to make accurate assessments, because there is so much.
I think the last paper in that blog is about treat to target. I think we physicians are convinced of the importance of treat to target, although this is not formally demonstrated in the context of systemic lupus. But we don't really have the feeling from the patients with a large sample. So this is really interesting, because this was an international patient survey about treat to target. And what we can say is that in the end, the patients agree that this is an important subject to be studied in clinical trials. And we also know that there are some difficulties for the inclusions in trials, but here the patients reported that they would be willing to participate in treat to target trials, although there are some specificities. So I think these are very encouraging results.
Okay, so I think this is the last abstract now, which is about biomarkers, isn't it? So this is about the study we mentioned earlier. This is the Beat Lupus study done by Mike Ehrenstein's group at UCL through the BILAG centers. And this was a randomized controlled trial, again, of a combination of Rituxan and belimumab. But in this case, what happened was they were based on the idea that you mentioned, Laurent, that after rituximab's given, the BLyS levels go really, really high, and that might promote B cell return and therefore be deleterious. So what they did was all the patients were treated with rituximab, and then after the rituximab, they were randomized to infusions of belimumab or infusions of placebo. And what they showed was that, just like the abstract you showed earlier, the patients who had the combination, it kept the double-stranded DNA IgG levels lower. And also, importantly, they got a clinical difference too, that severe flares, moderate severe flares, were different between those two arms. So it was clinically better to have the combination than rituximab on its own. So this was a reanalysis of those data, where they really did quite a lot with biomarkers. So they looked at autoantibody assays, quite detailed ones. They looked at cytokines, including interferons, using Simoa, these super sensitive assays that can measure serum interferon. They looked at interferon signature. They looked at BAFF. And then they did some quite sophisticated modeling, where they combined things like PD changes, association with response, steroid data, to try and understand the whole mechanism of which patients were going to do well with this combination. And actually, it was quite impressive how a fairly clear and very interesting answer came out of all of that, which is that it all seemed to center around IgA anti-DNA antibodies. So anti-DNA antibodies of the IgA2 class, essentially those fell in belimumab responders, but not in belimumab non-responders, and not in patients who were having placebo, in this case placebo being rituximab on its own, you have to remember. So it looked really quite convincing. If you look at the abstract book, you'll see the figure they showed. And they also went on to do some other work to back up that, showing that when you could see the IgA2 secreting plasmablasts and the T follicular helper cells that were also falling on belimumab, and Ritux compared to all the other arms in the studies. It also seemed to relate to patients who had renal disease. So an interesting result that I found. I think I always knew that IgA autoantibodies were more resistant to rituximab, but the fact that blocking them with this combination was possible and seemed to clinically be quite important was quite surprising to me. Okay, so thanks both of you. I mean, that was just a very interesting fly through of all those abstracts. We're seeing all kinds of different data coming through that answer our questions and ask us new ones that we're going to address in future. There's some emerging themes there, aren't there, about different classes of therapies, phenotyping patients more accurately, understanding how to measure what's happening and how to tailor the therapies to the right patients. So I think that's been a really interesting discussion, and it's going to be really interesting to follow up these new directions in research as they emerge over future conferences and papers. So the EULAR on-demand content, that's available until the 31st of July. So if you get a chance, I recommend you go and look at the sessions on lupus that we've highlighted while those are still available. And that just leaves me to thank Laurent and Victoria for joining me, and thank you to you for listening.
Thank you.
We've got regular podcasts on the Lupus Forum that all of us participate in, so you can see us discussing the latest publications in lupus with sets of slides that you can download to use in your own presentations and teaching to summarize these papers like the ones you've seen today. So make sure you have a look at lupus-forum.com to keep up to date. And thanks for joining us. We'll see you next time.